everybody. How y'all doing? Good to see you. I'm going to talk today about body weight supported treadmill training. How many people here are already getting some form of this therapy, or their children are getting some form? How's your experience been? Good, bad? Can you tell?
Well, sometimes it's really doesn't need to be supported or the by the institute. But it's been really good. It's able to walk for started at like 25 and now it's up more than 100.
So the therapist is holding your son over a belt?
Yes, he's holding with his hands like this.
And they're walking.
She's holding his hips and making his legs do the right movements and of the sports.
So it looks good.
It looks great.
We've definitely seen an increase in stamina. So when he started off, you can only do it for a real short period of time, and now it's longer. That's where I've seen improvement.
It was very good. We did it at UCLA. It was great. He has a nice smooth gait, stamina increase. The problem is that it's very physically taxing on the therapist, especially if you have a big kid. And our child is almost 6 feet tall and wears a size 13 shoe. This is a big leg, and the therapists there are very small women. So every time he would go in, you'd see them with more wrist wraps, and it's very hard. I'm not trying to explain, but it's very hard to move someone's leg like that. But he has a nice gait this weekend because of it.
And is there anything in specific that you want me to try to cover before I go into my spiel? That's Sandy talking. Yes?
I just don't know. I haven't kept up in the last year. They do the same thing, and they move their legs. Therapists do. And if they can come up with anything that it does it for them, they can still protect the knee like something that's paralyzed that doesn't belong at all. Do themselves, that I can do with them.
We did a stationary bike that you move the arms and it does the pedals.
How do you protect the knee? Don't go.
It's far enough out that it never hit the knee. We put her foot in a swimming sandal, Velcro sandal there, and put her foot in, and she does the bike herself.
Other things that you're curious about that you'd like me to touch on?
One thing with my son, we did serial casting, and a side effect seemed to be of the serial casting that his gait improved, and they thought maybe it was because of the weight of the cast and the proprioception. That perhaps that improved that for him, and it was like before that he was not independent in his walker, and after we did the serial casting for about 6 weeks, and he had these heavy casts, he really started to ambulate independently with his walker.
This is the UCLA is the only place in California where I know this is broken down all the time. They don't get funding problem, because in Chicago, a lot of the kids' hospitals have them, and they can't afford the one with the hydraulics, so we're always changing the straps, which can be time-consuming. And if there's like 7 therapists and there's only one body weight support system, everyone's kind of like, you have to sign up for time.
All right. I'll launch in and try to touch on these things to the best of my ability, and of course there'll be question time at the end. First, I want to acknowledge Andrew Behrman, who's a PhD physical therapist at the University of Florida, and I've taken her slide program and edited and thrown my own stuff in. So if you like it, she deserves credit, and if you don't like it, she doesn't deserve blame. What I'm going to try to do is talk a little bit about current rehab approaches. It sounds like you probably all are very familiar with rehab approaches. And then I'll review the suspended treadmill training and comment on applications, potential limitations, and implications. We switched format so we can now have kind of the Russian version of my talk. This is a quote from Corbett, who's an editor at New Mobility, a spinal cord injured gentleman. He says, rehabilitation's job is to take your body as it is and to maximize your capabilities within recognized limitations. This is a difficult acknowledgement. Rehabilitation seems only second best. To fully accept rehabilitation, for most of us, is to effectively abandon recovery. Rehabilitation can give you strength, re-education, skills, and reintegration, but no cure. So there's always been this kind of tension between, if we rehab, does that mean that we give up hope, or that we acknowledge that there's something wrong that's not going to be repaired? And it's difficult for parents, for kids, and for rehabilitationists. I actually think that the treadmill training starts to change this view of things. But treadmill training isn't really the standard of therapy, as you all know, and that's why you're having a hard time getting a hold of it. The standard approaches are really as follows. You take a look at somebody, you figure out what is it they can do, what is it they can't do, what could you strengthen and help them compensate with, and if you can't restore the lost abilities, how can you get those things that they can do well to be even strong to help them get along? And then, again, I saw that Dr. Pidcock talked about predictions, and I'll light on that a little bit. So in a rehabilitation setting, we're trying to get maximal functional independence. Again, we've got a gentleman here who looks like he's in pretty good shape, but he's in a wheelchair. So we assume that he's got lower limb weakness, probably from a spinal cord injury, and he's going to get along in life well because he can compensate with upper limb strength. He does well functionally, but he's not restored. He's not walking. Again, from a rehabilitation standpoint, that's a pretty good outcome, but not necessarily from the view of the patient. That's a whole other thing that I'm not sure that physicians can approach too well. We work to get people stronger and to improve their endurance and range of motion. And we teach new ways to do things. Again, the we is, it's obviously not physicians alone, and actually sometimes physicians are the smallest player on the team, and it's you face-to-face with therapists. Things that physicians have used up until now to predict ambulatory function after spinal cord. Well, level and severity of the injury. In rehab medicine, it turns out that there's some very simple and constant rules that really cut across diagnosis. And one of them is the worse it is, the harder it is to come back from, and the less severe it is, the easier it is to come back from. And that goes for spinal cord injury from whatever course. Volitional motor control or volitional muscle strength in the arms and legs. If you have more, it's easier to do more things, and you don't have as far away to climb back. These aren't 100% rules, but they're probably 90% rules. How many of you are familiar with the American Spinal Injury Association, or ASIA's classification? Okay, a few. The ASIA classification, I kind of do this for your own education because it's kind of the language that a lot of physicians and therapists speak about when they talk about spinal cord. And this is, or spinal cord injury, this is a way for practitioner A to talk to practitioner B, and we'll know what we're talking about. Basically, when you do the physical exam, you look at the muscle strength in key groups, elbow flexors, wrist extensors, elbow extensors, finger flexors, and finger abductors, and you rate them on a scale of 1 to 5. Actually 0 to 5. 0 is nothing there, 5 is it's normal, and the other numbers are in between. And you get numbers, and you put them in those slots, and of the lower extremity is hip flexors, knee extensors, ankle dorsiflexors, long toe extensors, and ankle plantar flexors. So you have a potential of 100 points, 5 in the upper limb times 2, because you have 2 upper limbs, so 50 in the upper, 50 in the lower, and you get points of 100. And then you also take a look at sensation, and this is a dermatomal map, or it's that when the spinal cord comes out, it gives branches, and those branches, in an organized fashion, give sensation to the body, and you can then rate the presence or absence of light touch and pinprick, 0, 1, 2 scale, and you end up with a maximum scale of 112. And again, this is more just if you run across this, or if you're trying to figure out that someone says your kid is a C5 tetraplegic or a L3, this is how it's determined. It's done by physical exams, not really done necessarily by what showed up on the MRI. We also classify the completeness of injury. And this is kind of the opposite of school, which is A is worse, E is better. And A is a complete injury. We tested your muscles and we've determined that you've got a C7 tetraplegia because the muscles above C7 look pretty good, the muscles below C7 look, there wasn't much there. And you also had no sensation or function below that level. That's a complete injury. Incomplete, B, incomplete is you have sensory function, but really no motor function. C is you have motor, but not enough to go against gravity, and D is you have motor and enough to go against gravity. Again, I don't think it's really important that you memorize the system, but just that you know it's there, and if you're reading papers or if someone's talking about the abilities or potentials of you or your children, that might be useful to know. So here's a blurry picture of someone with an A to C. He's got some muscle ability below the level of lesion. I'm assuming it's above the lumbosacral region. And he's getting some help to walk with some assistive devices. But the D guy, who's got more strength enough to go against gravity, is doing it with himself with braces and a walker. So when we've tried to predict outcome in spinal cord injury, again, I apologize if this is stuff you've already heard before. Here's a few papers. Waters looked at 36 patients with spinal cord injury that completed the GATE program. And his question was, does this ASIA score correlate walking ability? And he found that if the lower limb score, again, there's 5 muscles, 5 points for each muscle, times 2 legs, a total of 50 points. They had 30 points. They did pretty well. They had a speed of almost a meter per second, and they got out and walked. But if they had less than 20, they went about half a meter per second, and usually decided to use a wheelchair. Why do they use a wheelchair? Because after a certain point, you do what's practical. And if you don't have enough ability, a wheelchair is more helpful. Burns examined 105 patients with ASIA C or D. Remember, C and D are more abilities. And they looked at them, can you predict from the time that someone enters the hospital what they're going to look like at the end of things? And basically, people with an ASIA D, if that's as low as you went, did pretty well. They came out and they walked well. Walking is defined as 50 feet without assistance of another person. Now, if you were a sprinter, that might not be so good. But if it was C, if you were younger, you had a better prognosis. The Crocher, another study, 27 patients. Initially ASIA B, that's higher up, so worse ability. And they found that if you had an intact pinprick, that was predictive of a better outcome. But if you had touch without pinprick, that was not such a good outcome or income. Okay. And then also looking at strength itself, recovery of quadriceps. Those are those big muscles that help extend your knee. And they looked at 17 patients with a C4 to T10 incomplete, and those with 3 to 5 quad strength at 2 months became functional ambulators by 6 months, but those with less than 3 only a quarter of them did. Again, it kind of gets to the, what are you supposed to take away from these studies? And I don't think what you're supposed to take away is this is true for every patient. I think it's really the trend. If you have more to start with, you end up with having more, going further because you have more to work with. But nobody necessarily is closed out. And the other problem with these studies is these are all based on our current or recent past level of treatment. Well, our recent past level of treatment hasn't included body suspended treadmill, hasn't included emerging medical treatments. It's important to know what kind of medicine someone's on. And although I don't intend to talk about it today, a lot of medicines that might be useful to control symptoms might also interfere with the central nervous system's ability to reorganize. So these are all very tricky problems. So I wanted you to get the general flavor of what is out there, but I don't think it is preordained. Any particular person will or will not achieve a level. So then what happens if someone can walk with assistive devices? Do they walk with assistive devices? And Heinemann, out of the Rehabilitation Institute of Chicago, said that after spinal cord injury, if you needed to use orthotics and forearm crutches, people often opted for a wheelchair. So even if we're putting all our energy to get people up and going with a lot of assistive devices, there's a separate question of, do they use them? And how, I mean, my philosophy is it's up to the patient and their goals and ambitions, but I don't think it's necessarily a given that walking is better, any kind of walking is better than any kind of rolling. I think that it depends on the person, what they need to do, and what they want to do in life. But so just because you can get somebody up doesn't mean it's actually useful in the long run. And similarly, Waters and Lunsford found that those walking with 2 AFOs and assistive device tended to select wheelchairs as well. So this stuff is kind of based on a set of assumptions, and those set of assumptions pretty much are as follows. We assume that all willed activity comes from the brain. It tells the whole body what to do, and that the spinal cord works like telephone lines. And so the brain thinks up what to do, and it sends a message to these telephone lines through your spinal cord, and they tell the muscles what to do. And that after somebody's injured, has a spinal cord injury, these telephone lines are damaged, so they can't carry the messages very well, so people can't do the same things that they could do. And that's pretty much what they've got. And that damage from the spinal cord injury is permanent, and that the spinal cord doesn't reorganize. Obviously, these assumptions have been challenged. There's one of those challenges right now. So there's this relationship between clinical activity and basic science, and it often takes a long time to get a translation from what somebody discovers in the laboratory before something can get delivered to people like you and your children. And there's a whole body of literature talking about spinal cord injury in animals that is still in the translation stage. Here we've got a cat. You cut the spinal cord, and then you put the cat on a treadmill. Well, let me rephrase that. You cut the spinal cord of the cat and you leave it alone. Do you expect the cat to walk? No. And maybe you've seen animals pulling with their fronts and dragging their rear end behind. Well, if you take that same animal and you put them in a harness and you put them on a treadmill, so the treadmill's going around, and you help them place their hind feet, over a period of time, the hind feet start to step and walk in pace with the treadmill. This is a very interesting experiment. And what it does is it starts to take apart those old assumptions. If we assume that walking is all from the brain and the spinal cord simply relays the message, well, you don't have any brain relay anymore. So it should be impossible for the walking to take place. There has to be some walking mechanisms in the spinal cord beyond the level of damage for the walking to take place. I don't know how else you can explain how walking can take place after that spinal cord's been cut. So this ability to regain stepping is attributed to oscillating neural circuits in the lumbosacral spinal cord that interact with phasic sensory input. And let me go forward and then hopefully I'll make that clear. So what you have then is, again, this interaction between the basic sciences and the current practice. As we see that the control of walking isn't necessarily all brain dependent, then that challenges these old assumptions and kind of gives us this push or impetus to look at experimental locomotor training. Now, there's a family of therapies that's emerging to restore walking, and I've chosen body weight suspended treadmill training to kind of umbrella this whole emerging group of therapies. But, well, let me rephrase that. The body weight suspended treadmill training is kind of one of them and probably the most researched now and the most common. But there are others that are coming up, and so we shouldn't restrict our range to just the one. As I was preparing for this talk, I did a Medline search of all the articles I could find with body weight suspended treadmill training in some sort or another. And my intent was I will read all these articles and I will abstract all the information. I will present them to you so that you'll have a palette of information that you can then fit new stuff into. And that didn't work out too well. I found about a stack this thick. And as I was reading through them, I didn't find that there was a whole lot of differences from one study to the other. So I decided I would take a different course and summarize kind of one study that's typical and then tell you about the kind of flavor of the literature that's out there, at least from my standpoint. This study is from 1994. Loft band therapy based on rules of spinal locomotion is effective in spinal cord injured patients. There's two reasons I picked this study. One, this had a lot of patients in it. It had 89 patients. And most of the studies that I saw had 4 or 5 or 10. So I thought this would be a bit more applicable. It was an early study, so it's actually one of the studies that kind of helped spur people's interest in suspended treadmill. So let me launch into it. 89 patients were enrolled. 44 had chronic spinal cord injury, which was somewhere between a half a year or 18 years after their spinal cord injury. These are all adults. And 45 had acute spinal cord injuries. They compared these groups to people who had gotten conventional therapy. Some of those people, they did it in a historical manner, so they looked at all, they said, we'll take all comers from this point and we'll compare them to people before we had this therapy. That's the historical controls. And some of them underwent a conventional therapy before they underwent the body suspended training. They used a treadmill with variable speed and a harness. They used therapists to move the legs to stabilize the knees and ankles. And they typically started with that the harness would hold 40% of the person's weight. And the schedule was 30 minutes a day, 5 days a week. And the duration was anywhere from 3 weeks to 20 weeks. And if people started to be able to walk over ground or upstairs, they encouraged that and included that in the therapy. All the patients had some voluntary limb activity. They were judged to have, they were either using assistive devices to ambulate or judged to have the potential to use that. They didn't have contraindications. They didn't have things that would make it look like they would fail or be in danger. So they had no skin ulcers and no contractures that should prevent walking. Another reason I chose this article is the diagnosis. The diagnoses were described as most frequently trauma or traumatic spinal cord injury, followed by non-progressive myelitis. And they never talk about that again, and they never tell you how many people had the myelitis, but actually it was the only place I could find myelitis even mentioned in regard to body suspended treadmill training. So let's look at these chronic patients. They typically receive 3 to 20 weeks of training. The median was 10. And they had 12 controls participate in 5.5 to 8.5 months of conventional therapy prior to the body weight suspended treadmill training. And they used a 6-point scale, which basically 0 was they were in a wheelchair and they couldn't get up no matter what, and 5 was they were walking greater than 5 steps independently, and the gradations as you see. So there's a bar graph that made this all look a lot more understandable, but essentially prior to training, 17 people were in the 0 range. They were in a wheelchair, they couldn't get up at all, and none were walking 5 feet. And after training, only 1 stayed in a wheelchair. There was another one that got up with the assistance of 2 people, and now we've got 20 at a level 4. So we see a big shift in the population when they were treated with treadmill training. When they compared this to historical controls, these patients did a lot better than the patients that had gone to their facility in the 5 years previous. When they looked at acute patients, really the same thing happens. You start with 13 in the 0 in the wheelchair reliant alone, and none in the walking 5 feet, and then following the training, 22 are walking 5 feet. So they've shifted over. But those that got conventional therapy also improved. And that's what you expect when someone gets an acute spinal cord injury. If there's not a whole lot of complicating factors and if they don't have a progressive disease, they tend to get better. But they got more better with treadmill training. They did test or comment on 7 patients who had those complete lesions, who had no ability to move their lower limbs, and they showed no improvement. So this is kind of a translation of what we've seen in the laboratory, that volitional motor control or brain-centered motor control is not a prerequisite for the generation of stepping. You can produce some stepping without really having the brain involved. You know, I should have commented when I showed you the cat slide. The cat sitting there, we're telling you the cat is walking, but the cat is not chasing mice. The cat can only walk on the treadmill. The cat can't see something and run towards it, because in order to have that kind of activity, you have to have brain connection to tell those motor centers in the spinal cord increase, decrease, and things like that. Do you understand what I'm saying here? Yes. The question is, if someone's never walked, do they still have inborn abilities to walk? And do they have inborn spinal cord set up to walk? I think I know the answer to that, but I can't point the reference. If you take, if you take infants before they're able to walk, for the first months of life, part of what's going on for infants is their brains are getting myelin wrappings. And so they're kind of becoming more integrated. And if you take kids before they walk and you hold them up by their hands, you can get them to do stepping motions. Is that brain-directed stepping motions? I don't think so. I think that's spinal cord. So I would argue that there are some inborn walking ambulatory prepared circuitry before the brain can integrate everything and access them. Doug, you like that?
I think that's right.
Okay.
Probably that's completely right, although the degree of myelination of the motor centers and the cortex, but every time you see it stepping, it's actually quite a bit advanced.
But it's not necessarily based on learning. It's not that they've had the experience of walking and that has taught them to walk. It's that there seems to be a program ready there to go without experience, which is what I think your question was to. Right. It's response to, well, I'll get to that. It's response to sensory information going in produces motor response out without really a lot of without, I think, a lot of brain activity directing it.
Can you clarify a point in this study? Because I thought I heard you say that there was some lower extremity movement prior to the study.
Right.
Yet 7.
This is separate. They've commented on this at the end, that they also tried these 7 patients who had complete injury, and so I assume that they had no volitional control below, and they didn't benefit. So this gets to this point, which is you have to have more than the spinal cord working alone. You have to have some kind of brain connection, or you don't get anything that's useful. They were able to step some on the treadmill, but they weren't really able to translate it into anything useful.
You have to have
For us today, to get off the treadmill and use your walking, you have to have some brain connection. If you have a complete injury, I don't see that you're going to get a functional use out of treadmill training. You're not going to get you may get conditioning, you may get health benefits. That's a separate question, but you're not going to get the ability to do things, make stretching, all those things. You're not going to get the ability to do something.
So their legs could move on the treadmill.
Well,
You couldn't take that off the treadmill.
Right.
Do anything useful with it.
Right. And Christopher Reeves, I was going to get to this later. Christopher Reeves has done some treadmill training. I'll try to bring that up a little bit. Okay. And again, I've kind of already said this. The lumbosacral spinal cord is capable of recognizing, interpreting, and responding to functional sensory cues in a manner which produces useful motor response. Not just from the article that I've told you about, but from a series of articles. At this point, having some kind of body suspension in your training helps develop the ability to walk over ground if the person is selected correctly. Can improve how fast you walk, can improve the kinematics, or how you place the leg, how well coordinated you are. And some people have regained the ability to climb stairs. For those of you who haven't actually seen an experimental lab with treadmill training, we've already said that it's therapist intense. Yes? No? And this is Dr. Behrman again in her laboratory. And you see a gentleman with a spinal cord injury supported in a parachute harness. He's got a therapist behind. He's got a therapist directing the legs. And sometimes there'll be another therapist on the other side. Actually, there is another therapist on the other side. You can see the hand over there. So it takes a lot of human interaction at this point to make this system work. When we're talking about, I want to talk about the factors, again, we've already kind of mentioned this, that make treadmill training work. And the idea, again, is you're getting that these spinal cord centers are waiting for sensory input that looks like walking in order to get turned on to give you a walking output. So what normally happens in a rehab setting for someone who can't walk very well is we do a compensatory strategy. Well, you can't make your foot push down anymore, so we need to stabilize your foot, and we'll put it in a brace so that your foot doesn't collapse when you take a step. And you can't support your full weight with your legs, so we'll give you canes or a walker, and you'll support weight through your elbows. But the activity that we'd like to see is walking, which doesn't have those kind of supports. Well, if you're trying to run a marathon, how do you train for it? You train by running marathons. If you want to learn the fiddle, you got to practice that fiddle all the time to whose ever discomfort. So there may be something inherent in this compensatory rehab that doesn't activate the spinal cord as well as we might like, because the kind of sensory input that someone gets when they're leaning over on a walker and putting their weight through their hands and their joints are immobilized is not the phasic one-step, two-step joints move in a coordinated fashion, in a specific fashion. So these things, standing like this, you don't really want your spinal cord to start going, right? But that's what actually people have to do when they're spinal cord injured. So the compensatory strategies, which are good, and I'm not talking against them, they're wonderful. but they may not be triggering recovery. They're compensatory. Again, not bad, but in a new direction that we're heading towards from the laboratory to the clinic will be how can we encourage and take advantage of these inborn circuitry to produce motions that we want to see. Some specific stimuli I've kind of already mentioned, that loading, putting weight on joints probably helps activate the spinal cord centers. The speed, again, if you're struggling to walk with a lot of bracing, that probably isn't exciting the spinal cord motor centers that you want. So if you can make things go faster, which a body weight suspension can do, getting the hip positions in certain postures might help. And again, one of the things that two things also that the suspension does is it gives a person security. They can't fall, and they learn that pretty quickly. So that frees up your mind some, but it also keeps the posture upright like normal walking posture. So what's the status of this treatment today? From my review of the literature, there's actually a lot more literature on stroke than there is on spinal cord injury, and there's been Parkinson's as well. So this type of therapy can be applied to a wide variety of diseases. There are other variations of this type of training out there. One of the interesting ones, instead of using a treadmill that stands still, there's a track in the ceiling, and a person can walk on an actual floor while being suspended from a track in the ceiling. And the directions now in this therapy, as I read it, is refinement of technique, looking at factors such as how fast should the belt of the treadmill be going, how intense should the exercise be, is it better to have a half an hour a day, 3 days a week, or is it better to have 2 hours a day for a shorter duration? I'm not sure how much that's being discussed in body weight treadmill training, but it's certainly being discussed within physical and occupational therapy. There's also combinations of triggering EMG when someone's walking and their foot falls in a certain way. You can set it up so that that they get external electricity to their muscles to trigger the movement that you want. These types of things are being applied. So what's the relevance to transverse myelitis? Well, that's a very good question, which I asked myself. I could not find any reference other than the vague one that I mentioned earlier to this being reported in the literature for transverse myelitis. And I could only find 2 reports in children. One was a single case study, and the other was 10 with children with cerebral palsy. So as we've already talked about, this type of treatment is not widely clinically available, is not regarded as an accepted normal treatment for gait disorders following central nervous system injury, and getting insurance to cover something that is person intense is really difficult. And again, unless you are finding a loosening of that. This is people intense, and I don't know of any substitute at this point for proper joint positioning other than having an intelligent therapist look at things. I don't think that biking has shown to have the same kind of effect that body suspended treadmill or the upright ambulatory therapies. Not that biking is bad, again, it has many health benefits, but if you're training to walk, I don't expect that biking is going to be the pathway there. It may do some things. It may help you be loose. It may help your cardiovascular pulmonary functioning. It may decrease your spasticity, but to learn to walk, most of what we know is you got to walk. So what are you supposed to do with this information? Is treadmill training a cure? And I think the answer is no. It does not make people normal like they were before the injury, whatever that injury comes from. Is it valuable? I think so. Again, the literature that I could look at, I didn't see really any papers that said we tried a group of people on treadmill training other than the completely injured patients, and things were awful and nothing happened. It was a big waste of time and we had a bunch of complications. literature that I found is that generally there's improvement in pretty much all the groups that try it. Can you get this treatment? Well, again, that's not an easy question to answer. It's great if you have an experimental protocol. And there are centers that are doing this type of training for spinal cord injury, but I don't know if they would accept transverse myelitis as a spinal cord injury that they're looking for. I know it's being done for acute spinal cord injury. So you kind of have to hunt around. There are commercially available body-suspended treadmills, and I think they cost the facilities $15,000 or perhaps less than that. The less expensive treadmills that I've seen don't leave as much room for the therapist to get in there and position the feet, and they're a commercial enterprise. So just because somebody has a treadmill doesn't know that they know what they're doing with it, and you need to, as with all your other care for your children, you need to kind of keep your eyes on and make sure things seem sensible. Should you get the treatment? Well, I can't answer that. The literature would say it's still essentially an experimental treatment, but if you were to ask me personally, I'd say if there's not a reason not to, that you ought to get that treatment. If you can get it, I would suggest you try, because I don't see a lot of danger associated with it. I have seen some scraped toes and some achy knees, but I haven't seen bad things happen. Now, I understand that Chris Reeves, who has a complete injury, who wanted to do this to stay in shape, broke a leg. And there's a consideration. People who are sitting a long time lose bone density. And if you stand on fragile bones, they can break. I don't know how this would affect your children, and I haven't really heard about osteoporosis in children much related to inactivity, but it's well documented in adults. So it's not with no risk, but if you ask me, if I could get it for my kid, I would look into things. I might check, see if there's any reason to think that there's a bone density problem. I'd want to be sure that it's being done responsibly, and it's not just somebody, hey, I bought a $15,000 treadmill and now I'm going to charge you $100 an hour to do it. I'd want to make sure that the people knew what they were doing. I would give it a try. And the treatment periods that I see typically are 6 to 12 weeks, so I'd want to give it about 12 weeks and see if there are improvements. And if there were no improvements and it didn't seem to be doing much of anything, I'm not sure I would put all my investment in continuing it. But if there were improvements, I would go ahead. And as Frank said, there's also this tension in rehabilitation medicine between maintenance and therapy. And so the idea is that in order to get a physical therapy service for you or your child, you have to be improving. But I think there's a lot of situations where therapy keeps things okay and the withdrawal of therapy causes a decline. How you get that paid for is another issue. But again, in terms of the treadmill training, I would see what happens. And if you withdraw from the treadmill training and things get worse, I try to get it again. How you do this, that's a tough one. I put this bullet point, how to live while waiting. And the reason I put this in here is that, again, I think there's this tension of, there's a lot of excitement that cure for spinal cord injury is imminent. And so if cure for injury is imminent, should we be putting all our time, what should we do with our time? Should we be exercising every day, 3 hours a day, and stretching every day, because very soon there'll be a cure, and if we don't do this, we'll end up with contractures and weakness and decreased bone density, and we'll be in trouble? Or should we get on the tasks of going about our business the best that we can? Should we be sitting in a wheelchair and wheeling and learning how to be a wheelchair athlete and spending our time on the computer and expressing our human potential with the tools that we have now? And I don't have the answer to that question. But in my experience as a physiatrist treating people, I certainly have seen at least a few people. I think there is a danger of being obsessed with returning to normal. And I would encourage you to think about the balance that you're trying to achieve. You need to put in the time. Well, I can't say you. In our house, we have our own challenges that could go under a diagnosis, and we have to balance where the therapy begins and where the therapy ends, and what we accept and what we don't. And I think that people ought to be stretching, they ought to be loose, and they ought to be active, and they ought to be engaged in activities that are meaningful. Again, I'm not really sure who I'm addressing here, but I do think that there can be an unhealthy attachment to so-called normalcy, to the exclusion of enjoying life and activity as you are. So you didn't ask for that, but that's what I told you. What is next? What I think next is assuming that our economy doesn't collapse totally, assuming that we still have medical research, I think the directions are a convergence of medical, surgical, and rehabilitative treatments. I do not anticipate that we are going to be able to open up your or your child's spinal cord and pour in healthy nerve cells, and that you're going to wake up the next morning and walk. I think that there may be a time when we can put in, either through medicines or through surgical techniques or a combination, things that will help give potential for you to walk, but I anticipate that there's still going to be a rehab program. You're still going to have to learn how to use these new cells. So I think there's going to be a convergence, that the treadmill training and the locomotor training are going to be part 2 of the treatment after you get the medical treatment, whatever that is. So I think that hard work and training and dedication is going to be part of the formula no matter what we do technologically. And I don't think that's a bad thing. I think that's how it should be. Thank you for your attention. I'd be glad to take any questions.
It's really, we have a teen, she was 15 and a half when this happened, now she's 17, and you're saying that it's kind of up to her whether or not, she wants to get up in her braces versus whether or not she wants to live in a wheelchair. But I still find, and she also has ADHD, so she is somewhat like still immature, and so I kind of feel like, even normal teens, they're going through such hormonal changes that, kids don't always know what's best for them. And we have such a hard time for her to see that, with the functioning, that getting up in her braces, which, is kind of like we make her do, which she's okay with it once she gets up, an hour or 2 a day to keep all that strength in her body health, that she, that hopefully if we, establish this pattern, they say you have to do something in your brain, that we just can't let her sit back and say.
I'm not suggesting for any particular parent any course of treatment. And I'm not suggesting don't push your kids to do things that are difficult, that are good for them. I just think that all I actually was trying to do is that sometimes I think, again, I may be addressing a problem that doesn't exist. Sometimes I think that there's such a promise that everybody's like looking for this golden thing ahead, and they're kind of missing the things that are in front of them. I don't in any way mean to say that you shouldn't push your kids to do what you think is sensibly right for them, and that can include ambulation and training and getting up in braces. The counter example, I saw a patient who had a spinal cord injury that was not due to transverse myelitis, and she was a young woman in her 20s. She was totally flaccid below the waist. She had nothing. But she had this conviction that she had something. And she would move this way or that way, and gravity would move her leg. And she would say, "Look, I'm moving my leg." And spent 3 hours a day writhing on the floor, flopping from one side to the other. And again, I really don't mean to be addressing anyone personally on in my view, she was doing something that was destructive to herself, which was following a therapeutic program that didn't have really any promise in it, and she would have been better off applying herself to a wheelchair life. That balance point, she's an extreme example. That balance point is for each person to do, but I just really kind of wanted to open up as kind of a discussion for you, for yourselves. You may be already talking about this, but
You're exactly right. That balance between therapy and in the beginning is like the hardest thing for parents, I think. I think, you know, you just, it's very, very difficult, so it's great that you guys have it.
thank you.
Sort of follow up on that. How much time should someone spend in the body weight supported therapy?
How many minutes?
How many minutes? How many times a week?
I don't have the answer to that either. Again, the typical protocols that I can see are a half an hour, 3 times a week seems pretty standard. I think it's hard to get people into the harness. It takes a lot of work. The patients that I've seen, the training is not necessarily an easy training. You don't necessarily come out of it refreshed. It can be pretty draining. Is that you're nodding your head? Is that your experience? Is not for you? Okay. So that's what the intensity is now. But I'm not sure if we know the answer yet. Maybe with a different type of suspension, that'll be longer, more intense. That's what I would say.
Ability improvements for kids and for parents is like discovering gold. I mean, you know, just those little bitty baby steps is just.
Again, for anybody that's in rehab who's worked with patients for a long time, cure is really not the measure of success. It's that little increment that allows you to do something that you couldn't do before. God, that's great. And if we can get you to self-cath and you couldn't self-cath before, I feel pretty good. I feel pretty good to be part of that. And I don't have any apology that you weren't playing football. So.
A lot of supported insurance made with motorized bicycles, staff, because it's not as labor intensive when you start to have like there are a number of movements just walking there and flying around bicycles, and that might be a way to transition, and it seems to be that it should be possible to create the bicycle movement that's not structured on the core. And if you do that, then you can make a movement that's semi-movable. That mimic the walking and get rid of all the labor.
Well, there's, elliptical steppers. I don't know. I know that was a study comparing bikes to upright walking at the University of Florida. I don't know. My impression was that the bikes didn't do as well. But I don't know if that's been published. I don't have any details on it. I think there's some possibilities. I'm not the person. I don't know the answer to your question.
I know about stuff in Japan. It was about the Syst and fine quality. They had this bad man having bicycles for a very long time, a very long period. And they saw that they were increasing muscle strength and all that, but they couldn't use it for anything. We didn't get the specificity better and didn't walk or anything.
Again, it's this task specificity of training. But again, that doesn't mean that any particular idea is good or a bad idea. There may be ways to use other activities to work out walking. Yes.
I have 2 things. Like, could you sort of like a regular treadmill somebody might have in their house, and in therapy centers they have things suspended, where they have the flat boards and swings and stuff. I mean, is it possible to not have a huge investment and still accomplish this?
The question is, can you patch together a treadmill, a body suspended treadmill? And I don't think the answer is no, and I'm sure someone's doing it somewhere, and okay, someone else isn't. But again, The problem is that it's not just the device, it's the therapists that are placing the legs. You need somebody that knows what they're doing. And I think if you don't, you do risk injury. I'm sure there's liability problems of any rehab center that did a slings and springs, body suspended treadmill without really knowing what they're doing. It would make me nervous if I was the medical director. I want to talk to you in 2 seconds about Power Assist.
Yeah.
Power Assist wheelchairs are wheelchairs that have some kind of small motor in the wheel, and you push the wheel and the motor gives you more juice and should protect your shoulders, which break down with repetitive use if it's long enough, or at least we think it's a factor. There are 3 Power Assist wheelchairs. One in the U.S. is available now. That is the eMotion from Frank Mobility.
What did you say, emotion?
It's like the word emotion, but it's
okay.
E.motion.
Okay.
And the cost is $5,000 or $6,000 plus. They're expensive chairs, or expensive. And what you get with that is a battery and a hub and a wheel. You actually don't get the chair, but you can pop those wheels onto an existing chair. I don't know if they make pediatric sizes of the wheels. There's nothing specific about the construction that would make it not be able to occur. I just don't know if it is occurring. Quickie has bought a chair from Yamaha, the motor company. It's the YW2. They are deciding, last I heard they were deciding whether to market it in the US, and I haven't seen it come to market here. And I don't know if those, I think you buy the whole chair, I don't think you buy the wheels. Delta Glide out of, I think it's Hamden, Connecticut, has a different Power Assist, and they're supposed to have their product on the market in October. I've been fairly well associated with this company and did some research showing the utility of that chair. My experience is that things take longer than they hope that they will, so it wouldn't surprise me if it didn't get to the market in October. So the chairs are out there and are, like a Cure, coming, but not always here. There are chairs available, and if you looked on the web, you could find Frank Mobility, and they would be able to answer your question.
We're going to have to break the lunch, but before we do, let me say, you are here for lunch, correct?
Yeah.
So you can have your way.
And also ask questions.
Okay, and hopefully, Dr. Levy will be here in the morning, our physicians who are going to be here for the discussion and answer questions. Thank you, Chuck, very much.